It's really a pleasure being here to this beautiful meeting that has become a classic, in the scenario of cardiomyopathies. So my title is, I suppose, if I correctly remember, Broadening the Spectrum of ARVC. So 30 years ago, as you remember, this disease has many putative fathers, I would say, including people from Italy, from France, from United Kingdom, from United States. But I would say that indeed our colleagues from Padova, Gaetano Tiene in particular, 30 years ago showed us that this was indeed a cardiomyopathy. And the news was particularly shocking for the community of cardiologists. The news was that a little involvement of the right ventricle, if you remember, the right ventricle was considered the dispensable ventricle. A small involvement of the right ventricle could cause the death of a man. Starting from this point, during the last 30 years, a broadening, a progressive broadening in the spectrum of this disease has occurred. From here, we did start. Then, in the next year, it became clear that this disease was responsible for sustained arrhythmias in the living man. It was responsible for variable phenotypes in a precise familial aggregation. Then it became clear that this disease could cause heart failure and, in general, severe heart failure. That this disease could coexist with left ventricular disease, or that a substrate resembling ARVC could involve in isolated way the left ventricle, so the left ventricle variant of this disease. And more recently, just to expand the broadening process, we have to face with mimics and phenocopies of the disease. We will focus on these points only. First of all, heart failure. What is the proportion of patients reaching the medical observation because of heart failure symptoms? Of course, it depends upon the clinical setting of your center. If we consider our center in Bologna, our center as a heart failure program and heart transplant program, as you can see that at presentation around 14% of the patients has signs and symptoms of severe heart failure. If you consider the follow-up of these patients, we can measure an incidence of 2.3% person here, and that at the end, about 1/3 of the cases developed heart failure symptoms. Who are these patients with heart failure, comparing with the other patients suffering of sudden death or arrhythmias? As you can see, and this is a strange phenomenon, these patients are not older. These patients are younger, 37 years old versus 47 years old. These patients more frequently have atrial fibrillation, and in general, for these patients, right ventricular function is worse, and also left ventricular function is worse. But let's go into a more detail. And let's consider not only living patients, but also hearts, hopefully explanted hearts. We decided to put together the experience from Bologna and the experience from Padova, and with Cristina Basso and Ornella Leone, we collected 36 explanted hearts. Males, 20 were males. The family history was present in 36% of the case. And please, again, note that the age at symptom onset was 32. As for genotype, we were able to genotype only 10 of these patients. The distribution of the traditional desmosomal genes is classic. trying to go into a functional detail, and not only to measure right and left ventricular function, but classifying the right and left ventricular function according specific phenotypes of contraction. You can see that in more than 2/3, how can I activate the movies that are inside the specific pictures? I don't know. It was simple with the mouse. I have no idea. Somebody can help me? No. Okay. Oh, fine, fantastic. It's only a matter of time. So, as you can see, in 72% of the cases, right ventricle was globally dysfunctioning. So a severe global right ventricular dysfunction was present in 72% of the cases. But please note at the bottom, this is an interesting subgroup. In about 1/3 of the cases, the problem was related to an extreme inflow dilatation leading to massive tricuspid regurgitation. So this is a sort of partial remodeling of the right ventricle. Unfortunately, the color is not present here, but you can imagine the degree of a tricuspid regurgitation. So the tricuspid leaflets do not touch. So very massive tricuspid regurgitation. Left ventricular hypokinesia in 63% of the cases, but left ventricular dilatation only in 1/3 of the cases. So I just mentioned the concept of inflow remodeling of the right ventricle. This is particularly important to understand the pathophysiology of this chamber. Of course, we took the opportunity of examining these explanted hearts and trying to assessing all the items you can see here, the cellular damage, the transmural or non-transmural fibrofatty infiltration, the fibrofatty infiltration of the left ventricle, the presence of phlogistic infiltration. And just to summarize a large amount of data, the concept is that as for right ventricle is concerned, you can see a massive transmural fibrofatty infiltration, constant in each case. But what the situation in the left ventricle? I can say that in each patient, at least 2 segments were involved. So left ventricular involvement is a constant feature of these explanted hearts, explanted due to severe heart failure. Of course, the degree of transmurality is definitely lesser here in the left ventricle as compared with the right ventricle. So the overall picture is this. The mechanism of severe heart failure in this disease is multifactorial. There are many components, the functional components I've just mentioned, but a constant degree of non-transmural fibrofatty infiltration with prevalent fibrosis in the left ventricle. This is the functional and histological phenotype of the cases undergoing heart transplant. Other times, we mentioned the fact that in this particular subgroup of cases with extreme and stage phase of the disease, the ECG is also very peculiar, and here you can see in these 8 cases, for example, D1, AVF, V1, V2, V6, the electrocardiograms are quite similar, and the typical electrocardiogram is characterized by microvoltage, fragmented QRS, or epsilon waves. In other cases, the look is not of right bundle branch block, but looks left bundle branch blocks. But once again, QRS duration is enlarged, and QRS are fragmented, and in many cases, epsilon waves are present. So when you see such an electrocardiogram in a patient with severe heart failure, this is a sort of red flag. You have to consider the hypothesis of a biventricular ARVC. But what about the problem of coexisting left ventricular disease or the problem of left main in this disease? What is the frequency of left ventricular involvement in ARVC? In the series I've just mentioned, the frequency was 100%. But if you consider series of living patients not undergoing to heart transplant, particularly well studied with magnetic resonance CT and CARTO, the proportion, the frequency of left ventricular involvement associated with right ventricular involvements is around 50%, 50 to 6%. But there are single cases with exclusively left ventricular involvement. And as you know, this is the real problem. This problem has been beautifully shown, underlined by colleagues from London some years ago. And I think that every center did encounter such patients. For example, this is a 29-year-old patient with cardiological anamnesis unremarkable. However, he has palpitation. This is the electrocardiogram. As you can see, non-specific or ischemic-like T-wave inversion, tendency to low voltage, no left ventricular bundle branch block. Many non-sustained ventricular tachycardia runs at the Holter, normal, pretty normal electrocardiogram, but despite this absolutely normal echocardiogram, definitely LGAD accumulation, subepicardial, non-transmural, non-ischemic in the left ventricle. The mother, same, very similar electrocardiogram, very similar echo, and very similar MRI. The cousin, once again, normal ECG, normal echo, but pretty abnormal MRI with LGAD accumulation at subepicardial or transmural level only in the left ventricle. And this is the family. But I'm sure that everyone in this room did encounter at least one case or one such a family. This is a more recent case. This was, unfortunately, a 40-year-old tennis player who experienced sudden death during the game. This is the heart specimen. In this case, AV valves were removed for the valves bank that is active in Italy. And please consider that the right ventricle is normal, the left ventricle is non-dilated, non-hypertrophic ventricle, but there are many areas of whitening. What is this whitening? Please, let's go with me inside the myocardium, and let's consider the histologic equivalent of that areas. Subepicardial fatty infiltration, subepicardial fatty infiltration, fibro-fatty infiltration with important cellular derangement only exclusively at left ventricular ventricle. Indeed, this is the anterior septum. The right ventricle was and is absolutely pretty normal. So what is the real frequency of the sort of arrhythmogenic left ventricular cardiomyopathy? Not considering as the denominator the patient with right ventricular cardiomyopathy, but considering as denominator the patient, the cohort of patients with dilated cardiomyopathy. It would be very important to know this possible frequency. We do not know. There are some interesting studies in the literature. In this case, for example, Perry tried to document the frequency of desmosomal gene mutation. It's not the same thing. We are sure that not necessarily desmosomal mutation in this context mean a real phenotypic expression of ARVC. But the concept is that in a certain proportion of patients with dilated cardiomyopathy phenotype and with left ventricles not necessarily bad, in particular is this very interesting paper, in left ventricle with left ventricular ejection fraction more than 35%, there are inside this cohort a cohort of patients with important anatomical abnormalities within the left ventricle that we can detect, hopefully not with the autopsy, but with the MRI. Of course, the question is, do we have to perform an MRI to all our patients with dilated cardiomyopathies? I would say yes. My curiosity in my daily life bring me to ask for an MRI to the vast majority of patients with dilated cardiomyopathy. However, the concept is that at the moment we are not able to precisely identify the subgroup of dilated cardiomyopathy patients at particularly high level of sudden death or sustained arrhythmias due to an arrhythmogenic left ventricular cardiomyopathy. In my opinion, once again, the old electrocardiogram is useful. For example, if you see a patient with dilated cardiomyopathy, no left bundle branch block, no important hypertrophy, with this kind of pseudo-ischemic abnormalities of the T, probably an MRI is justified. I'm finishing, broadening the spectrum of arrhythmogenic ventricular cardiomyopathy. Broadening, in the concept of broadening is not necessarily a positive phenomenon. No? As you can see, sometimes the broadening process can be excessive. And in my mind, this happened in ARVC. Some example. Young 25 years old or 20 years old boy, right ventricular dilatation, right ventricular derangement of the trabecula. Here you can see the M-mode echocardiogram. I do not want to tell anything. This patient was considered having right ventricular arrhythmogenic cardiomyopathy due to the right ventricular dilatation. However, please note that this is a paradoxical movement of interventricular septum. So probably this indirect sign of pre-tricuspid shunt could be important. And why not? Looking at the X-ray, and here you can see an increase of the pulmonary flow. Again, the importance of this sign. A simple atrial septal defect was not present, but magnetic resonance in this case documented the presence of anomalous pulmonary venous drainage, partial but definite. And this was the cause of right ventricular dilatation. Once again, why this right ventricle is so strange in this boy? Please note the bones, not only the heart. So deformation, skeletal deformation, and sternal deformation. Another example, 34 years old man, impressive derangement of right ventricular morphology, ACD. This is the electrocardiogram, strange, enlarged QRS, right bundle branch block, plus previous infarct-like characteristics, normal coronary arteries, sorry for the Italian, but in this case, the suspicion of sclerodermia led us to the execution of this CT, and so the diagnosis in this patients who at the end underwent 2 heart transplantation was sclerodermia. Please note the potential of mimicking right ventricular arrhythmogenic cardiomyopathy in this case. But the coronary arteries unravel the mystery in this case. And yet you can see the typical hypertrophic aspect of the microcoronary circulation due to this terrible situation that is sclerodermia. If we consider the results of our experience, so around 200 patients reaching our centers with a preliminary diagnosis made by other of ARVC, at the end of the diagnostic process, definite 23%, borderline possible 22%, unaffected 42%, but more interesting, a sort of mimics. What mimics means? In my mind, mimics is not necessarily a diagnostic error. Mimics may be a condition of a real right ventricular abnormality, a sort of phenocopy, I would use this term. For example, Emery-Dreyfus, please, hemosiderosis, systemic sclerosis, sarcoidosis, previous myocarditis, and so on. How can we consider these cases? These are cases of phenocopys in the sense that a genetic disease or a non-genetic acquired disease creates a phenotype, instrumental, but also morphologic, but also ptoctic phenotype that is hard to distinguish between ARVC. Of course, so this is another important observation, is that the application of the criteria suggested to us by the task force does not protect against this type of error. If you apply in a rigid way the suggestion of the task force, we risk to perform a final diagnosis of ARVC. Why? In my mind, the pathogenesis of the cognitive error is multidisciplinary. Sometimes there is a problem of superficiality. Lack of methods is a great cause of error. Lack of knowledge is an important cause. But recently, another important cause is the excess of knowledge, excess of recent knowledge. We have written a lot of papers dedicated to ARVC. We have filled the international literature with centuries and centuries of papers of this disease. I'm looking at you, Perry, but casually. And the risk is that our reader perfectly knows everything on this disease, but doesn't remember the phenotypic and electrocardiographic and echocardiographic features, for example, of the pre-tricuspid shunts. So the excess of recent knowledge is a risk. And another risk is the use of generic diagnostic labels that characterize, unfortunately, some parts of our daily activity. So, dear colleagues, broadening the spectrum of ARVC, yes, this is a good process, an interesting and challenging process. I think that our main problems at that time is trying to protect ourselves against this enemy, but also we need a more formal nosographic intervention, since the nosography of this disease, in my mind, can be optimized. And probably scientific society, European or USA scientific society, in the future, probably could provide a better organization of this knowledge. Thank you.